Next, we would like to invite Dr. Debashis Dutta, who will be speaking on negative dysphotopsia, a futuristic approach. Dr. Debashis, sir.
Yes, thank you, AIOC and the respected judges. I'll be talking about this burning question of negative dysphotopsia, which follows a futuristic approach, and it is in the immediate uncomplicated phacoemulsification in the postoperative period. The incidence is as high as 12 to 45% as stated in the literature. It comes down later to about significantly, but in the immediate postoperative period it is high. There's optical factors, secondary factors, and neuroadaptation which goes into its understanding. There's a temporal crescent-like thing, Hod's blinders, which occurs due to in the immediate postoperative period when the bag is transparent. When it becomes opaque, then the scotoma goes away. Now the burden per year, considering the fact that India does 83 lakhs in a year, at 55% of it, 55 lakhs is phaco, so 15% of that tantamounts to 8.34 lakhs of ND in the immediate postoperative period, though it may come down to later on. So what are the management strategies? The management strategies are many, of which two seems to work: the reverse optic capture and the bag to sulcus exchange. So you bring out the IOL from the bag and place it in the sulcus. So we have Dr. Samuel Muscat manufacturing an IOL whereby the optic is partially in the bag and partially in front of the rhexis. So points to think under the apple tree. So we do maneuvers like sulcus placement of the IOL. This compromises the effective lens position and the centration, and reverse optic capture brings out the sharp optic edge in front of the rhexis margin, leading to iris chapping and pigments release, blah, blah. So what is the solution under the apple tree? So I think of placing the haptics in the sulcus and capturing the optic in the bag below the rhexis. This is a small video. This is the anterior haptic going below the iris in the sulcus. The second haptic is being dialed in the same place. And the optic, we nudge the optics below the rhexis margins at the two ends, two semicircular areas. I mean, one more, the second haptic, and then the optic is negotiated below the rhexis margin. So this is the postoperative period in retroillumination. We have this is the rhexis margin, optic below it, and haptic in front of it. So in due course of time, it may be opacified, but that does not cause any harm. So we did a study where by 5 millimeter rhexis and was done, and the uneventful phacos, and a telecolor used to call it on the 2nd, 3rd, and 90th day postoperatively about the negative dysphotopsia. To our surprise, we found that in the immediate postoperative period, the incidence of negative dysphotopsia in our case were 3.5% only vis-a-vis 15 to 45 or even 67% reported in the literature. If it is a solicited call, you ask the patient that and this 3.5% is we ask the patient actively that are you having this, rather than depending on the patient reporting it. So, and it comes down to 0.2%, 0.4% later on, that these are not important. So what is the aim of the study? The reduction of negative dysphotopsia through strategic IOL placement is possible, and future innovations and IOL designs can be based on this. So we have ignored this negative dysphotopsia for a long time, ever since we're doing uncomplicated phaco within the bag placement of the IOL. So it will go away, that's what we say to our patients. But these days where there's a flurry of premium IOLs, and we promise the sun to our patients. So if they are dissatisfied, I think the industry will think how to do away with this negative dysphotopsia. And now I think the time has come. These are my references. Thank you.
Thank you, Dr. Debashis. Judges, please.
Very nice presentation. First of all, the calculation of a percentage of Indian people getting this negative dysphotopsia may not be correct. You talked about 83 lakh surgery being done in India.
According to 22-23.
Of that, 80% are SICS, and they are all hydrophilic lenses. And we know that negative dysphotopsia are normally seen with the square lenses in the bag.
Hydrophobic
so you have left with only 20% of cases. Of that, percentage will be less. Okay. That's okay.
Okay.
Second important thing, Now, if we shift to your theory of putting multi-piece lenses the way we are putting, that means we are negating the advantage of multifocal lenses of these patients at this present time. Because we don't have the multifocal lenses or trifocal lenses in this design. So we may have to think in that direction also. Third point is, you're shifting the lens implantation, the effective lens position is going to be, anterior to the what normally we calculate. So that
Yes.
part we have to look into also, how to look into new effective lens position for the newer generation IOL power calculation. Other important thing will be now you putting a distance between the bag, that is the posterior capsule, and the IOL. So you'll have a very high chances of
PCO.
posterior capsular opacification or some sort of fluid collection happening in these cases because you have space. If you remember, there's a beautiful surgical techniques by lady Tessinganon. She does the in the back implantation where she does both anterior and posterior capsular axis and put the lens in captures into those areas. So in your technique, maybe in future we take out the entire posterior capsule and we fix the lens like this, which may take away the
can I answer
PCO
that?
happening in future.
Can I have answer them?
Yeah, yeah.
So here we are defining we have taken it that the plane of placement is the sulcus. So we can titrate the biometry according to the sulcus placement. Now this is a study whereby I do not place single piece lens in the sulcus. I have done it so that no eyebrows are raised. Therefore, I have to put in multi-piece lenses. But lenses can be designed with a trifocal optic with, like the resume and all that. It is possible to design. So the industry can have a think that, of designing it that way. It's a question of lens design. And effective lens position is defined here, is the sulcus or a little below that. So we can titrate it. And PCO remains to be seen. Even with acrylic premium lenses, we have lots of PCO, no financial, particularly IQ, there's so many. Yes, PCO is a concern, I agree. But my question here is to address the negative dysphotopsia, which is very high and annoying. That's what I have been trying to address here. So, and the incidence is really less. And we can try it out, anybody in our normal setup, no extra thing done. We don't need to do YAG, not this cutting of the IOL inside the bag, not a secondary procedure. It can be done as a primary procedure. Yes, any questions?
Any more questions?
Just one question. So how do we select the patients? We don't know whether this patient will go for a negative dysphotopsia. It's only after you have given the IOL. Suppose I've given a premium IOL. So how do I have to either replace it or I do a optic capture? So how do I know and plan beforehand giving him a 3-piece? That is the thing. You have done a study. It's fine. The study is fine. I'm saying. So it's like we are going back to giving 3-piece IOLs.
No. Like we had multifocal IOLs with 3-piece IOLs, like resume and all that. So maybe the newer trifocals, some company can come up with this 3-piece design with a premium optic, and we can give it a try. It's no way we can judge it beforehand because everything is unknown.
Yeah,
But these results are.
Yeah, thought process is fine. Thank you. But what sir was talking about that. Mary Tagishan's lens that we use in pediatric cataracts, but it is not very common over here. So she has done a very good study in Belgium. So that lens has a very less PCO and that can also take care of this negative dysphotopsia.
Yeah,
Yes, I have other
that has a
thoughts
little
in mind
surgical
also.
difficulty, that technique is little difficult.
Yeah, difficult.
But the concept keeps changing. The sulcus implantation was the initial thought. We all shifted to in the bag implantation, thinking that is a much more physiological space. And coming back to sulcus again it requires a rethinking.
The haptics in the sulcus, optic is still in the bag.
Because haptics are the one which are main concern. They are going to rub against the entire posterior area. Depends on what is the anatomy of those people. Never know these haptics may be touching the posterior part of iris, uveal tissue. Sometimes they
That's why I did it with multi-piece lenses
you
for
need
the
to do
time
a
being.
long-term study to see what are the hidden inflammation happening in these
So I
patients.
think I need ethical clearance for placing single-piece lenses in the sulcus with optic captured in the bag. I'll do it in due course of time.
Again, that's the single piece also very difficult to fix like
Yes.
that.
Even the post-operative opacity almost became slit-like in a long slant patients?
It is 1 year, almost nearing 1 year I've done this study. Not much, not so something alarmingly significant which we don't see in our day-to-day practice. It is not that all this are coming, running to for an RPC.
As a retinal surgeon, I will be concerned about my visualization of the periphery because it's now becoming slit-like. The patient's visual access may be still clear.
No,
not
no
with the
patient complains about that little bit of opacification of the rhexis margin. That is not complained about.
Thank you.
Thank you so much.
Vinit, you have a question? No,
This is
okay.
basically the treatment for negative dysphotopsia.
Yes.
So if you have it, you do it.
This is definitive
This
treatment.
is like prevent.
And somebody, if he or she is having it in one eye, you don't
Then
want
you
to
can think of
brush
it in
him
the
the other
other
way
eye.
around, and then in the next eye you want to be dead sure. So I think this is a technique to go for, hands down.
Thank
And
you,
USK.
Dr. Debashis.
Thank you.